The emergency department operates on a strict economy of attention. When a patient with a known history of epilepsy arrives experiencing a seizure, the presentation can easily appear routine. The diagnosis is already established, and the immediate clinical path seems straightforward: stabilize and observe. To test the safety of that assumption, researchers conducted a prospective, multi-center observational study across 34 public hospitals in Malaysia, tracking a cohort of 521 patients with established epilepsy presenting to emergency departments with seizures. Status epilepticus, or SE, is defined as a seizure lasting over 5 minutes, or recurrent seizures without recovering consciousness. Zooming out to the 521 patient cohort, exactly 119 individuals, 22.8%, met this strict definition during their ED stay. Nearly 1 in 4 patients in this population experienced a severe neurological emergency. Clinicians evaluating known epilepsy patients cannot treat these arrivals as low acuity events. The statistical probability of an active crisis is simply too high. Across the entire 521 patient cohort, the overall in-hospital mortality rate set at 3.5%. However, analyzing that flat percentage obscures the specific drivers of those fatalities. To isolate the true lethality of specific conditions, the researchers utilized adjusted odds ratios, or AOR. This statistical method controls for other confounding variables in a regression analysis, revealing the independent, standalone impact of a single diagnosis on survival. Comparing baseline mortality, a status epilepticus diagnosis carries an adjusted odds ratio of 9.17, independently multiplying the risk of in-hospital mortality by over 9 times. The only other independent mortality predictor was a history of prior ischemic stroke, carrying an adjusted odds ratio of 5.75. Because SE operates as a near 9-fold mortality multiplier, waiting to react to its onset is a dangerous strategy. Emergency physicians need a method to predict which patients are most likely to develop the condition before the neurological cascade begins. The researchers applied a logistic regression analysis to the cohort data to identify patient characteristics present at admission that statistically predict the onset of SE. They isolated 5 independent variables. We organized these findings into a clinical dashboard. The horizontal axis measures adjusted odds ratio for developing status epilepticus. First, for patients 60 and older, odds increase to an AOR of 1.79. Second, if the patient uses phenytoin, the AOR reaches 1.98. Before a physician even orders a metabolic panel, a patient's basic triage details, their birth year, and their current medication list already establish a compounding baseline risk for an SE event. The next layer of risk emerges from systemic imbalances. Common metabolic derangements act as powerful catalysts, driving the nervous system toward continuous seizure activity. Returning to the dashboard, elevated blood glucose upon ED presentation, hyperglycemia, pushes the risk higher, hitting an AOR of 2.08. Similarly, low blood calcium levels, or hypocalcemia, further amplify the probability of SE, reaching an adjusted odds ratio of 2.50. The final independent predictor dwarfs the demographic, pharmacological, and metabolic factors entirely, representing the single most critical red flag in the emergency department. On the dashboard, a suspected central nervous system infection generates an adjusted odds ratio of 7.80. This variable commands the largest adjusted association with SE onset in the study. While metabolic abnormalities double the risk of SE, clinical signs of a CNS infection place the patient in a critically high-risk subtier, requiring maximum vigilance. Looking at this map of the 34 participating Malaysian public hospitals, the geographic scale of this prospective study provides highly relevant epidemiological data for Asian healthcare settings, an area where detailed SE predictors have historically been limited. The value of this data relies on translating these 5 predictive variables and the 2 major mortality drivers out of the medical journal and directly into rapid triage protocols. The clinical pathway begins at a screening gate. Epilepsy patients arriving with seizures require immediate chart review. Triage cross-references advanced age, phenytoin use, abnormal glucose, calcium, and CNS infection. If present or with prior ischemic stroke, protocol dictates immediate intervention. Status epilepticus in established epilepsy patients is a highly lethal complication, but as the data proves, it is also mathematically predictable. By utilizing data-driven risk stratification at the ED door, clinicians can anticipate the crisis and act before it compromises the patient's survival.